Hi, welcome to week 2. In this presentation, we'll be discussing nausea, vomiting, and diarrhea, which are very common complaints that you'll be seeing in your primary care office. This lecture was developed by Miss Erin Kennedy, MS, FNP. She's an expert in the field of gastroenterology and works in a GI practice in Dayton, Ohio. The presentation is being narrated by Dr. Tracy Murray. Now, when a patient presents to the primary care setting with complaints of acute onset nausea and vomiting, a thorough history will be key to forming your differential. You'll find that a bit of detective work is necessary, and that the circumstances surrounding the episode or episodes can give helpful clues to the cause. Nausea and vomiting can stem from different conditions in several body systems. Gastritis associated with alcohol consumption or drugs such as NSAIDs, aspirin, antibiotics, and illicit substances are a common cause of acute nausea and vomiting in adults. Nausea and vomiting are listed as adverse effects of many prescription drugs, but can also be the presenting symptom for many diseases such as hepatitis, myocardial infarction, and peptic ulcers. However, the most common cause of nausea and vomiting in adults and children is acute gastroenteritis, and we'll call this AGE. This is what we're going to focus on in this lecture. Be sure to look at Chapter 11 in your textbook, which discusses some of the other causes of nausea and vomiting. Now, acute gastroenteritis, or AGE, is essentially an inflammation of the stomach and intestine. When inflammation of the stomach is predominant, nausea and vomiting are prominent symptoms. When the intestines are most affected, abdominal cramps and diarrhea dominate the picture. However, it's not uncommon for patients to present a framework with extensive inflammation, suffering from vomiting and diarrhea at the same time. Pathophysiological causes of AGE are numerous. However, viral, bacterial, and parasitic are the most common, with viral being the most likely. We'll discuss some of these pathogens in greater detail shortly. Now, AGE is characterized by a rapid onset that lasts less than 2 weeks and may be accompanied by varying degrees of nausea, vomiting, fever, diarrhea, or abdominal pain. Both vomiting and diarrhea are usually present, but either can occur alone with AGE. Symptoms depend on the underlying cause, but may also include fatigue, malaise, anorexia, tenesmus, and borborygmus. A careful history provides clues as to the causative agent and the suspected vector of transmission. So you'll want to ask your symptomatic patients if they've recently eaten any raw or undercooked food like sushi, traveled out of the country, or had any sick contacts. An antibiotic history should also be assessed. The duration of the illness is important in the differential because acute diarrhea is usually caused by infectious agents, whereas chronic diarrhea usually has a non-infectious etiology. The physical exam is usually normal, except for the aforementioned GI problems. Depending upon the degree of dehydration, mucous membranes may be dry, and vital signs may reveal tachycardia and orthostatic hypotension and/or dizziness. Viral gastroenteritis can be caused by several viruses. Norovirus is the leading cause of acute diarrhea for adults, whereas rotavirus is the leading cause of gastroenteritis for the pediatric population, especially for children up to 2 years of age. However, the incidence of rotavirus in children has fallen significantly since the introduction of the rotavirus vaccine. It is possible for adults to have a rotavirus infection, but generally it is less common and clinically much milder in presentation. Other rarer viral etiologies include CMV and herpes simplex virus, and they tend to occur more often in immunocompromised patients. So if you suspect AGE, what testing is indicated? Stool studies are not typically indicated for non-bloody diarrhea and if there's no evidence of systemic toxicity. In the otherwise healthy adult, the disease will normally run its course without incident, and there's no need for extensive testing. Selection of the most appropriate test is based on information received from the history and physical exam. If a patient appears to have signs of dehydration, serum electrolytes including sodium, potassium, and creatinine should be measured. Ordering a complete blood count does not help to distinguish between viral and bacterial enteritis and may or may not be elevated in the presence of AGE. Stool studies are indicated for patients with severe or prolonged diarrhea, and stools should be examined for the consistency, blood, and fecal leukocytes. Stool cultures should be performed on any patient with severe diarrhea, a fever of greater than 38.5 degrees centigrade, bloody stools, or stools that test positive for leukocytes or occult blood, because these symptoms are indicative of diffuse colonic inflammation, likely from a bacterial pathogen. When ordering stool studies, you need to check with your local laboratory for specific ordering instructions and identification of the correct collection tubes. You only want the patient to have to do this once. If your office does not have the testing capacity to examine stool for leukocytes directly, a sample should be sent to the lab to test for WCs and blood. In most labs, routine stool cultures will identify the presence of Shigella, Salmonella, Campylobacter, Aeromonas, Yersinia, and certain types of E. coli. A separate test, ova and parasites, should be performed to identify Giardia and Cryptosporidium, which are not reported as part of a routine culture. If you have a patient who recently traveled out of the country and presents with acute onset of nausea, vomiting, and diarrhea, you should consider traveler's diarrhea. Common pathogens responsible for traveler's diarrhea are usually bacterial and include Shigella, Campylobacter, and E. coli. In patients with epidemiological evidence, stool samples should be sent to the lab for routine culture, and specific enteropathogen studies that are not normally detected with routine stool cultures, such as enterohemorrhagic colitis, which is E. coli, and Vibrio cholera. Finally, any patient who develops diarrhea after initiation or completion of antibiotic therapy should have tissue culture assay or ELISA test for C. difficile toxin. The differential of acute gastroenteritis, particularly in patients with persistent or chronic diarrhea and severe abdominal pain, should include IBS, irritable bowel disease, such as Crohn's or ulcerative colitis, ischemic bowel disease, partial bowel obstruction, small bowel diverticulosis, and chronic pancreatitis, to name a few. Although most cases of AGE can be treated on an outpatient basis, you should be aware of red flag symptoms that identify patients who may need hospitalization or evaluation for other causes. These include severe volume depletion, dehydration, abnormal electrolytes or renal function, bloody stool/rectal bleeding, weight loss, severe abdominal pain, prolonged symptoms greater than 1 week, hospitalization or antibiotic use in the past 3 to 6 months, pregnancy, or advanced age. So how do we treat AGE? AGE is usually self-limiting and resolves within a week after onset of symptoms. Treatment should consist of supportive measures, including fluid replention and nutrition. There is no evidence that a BRAT or low residue diet, such as bananas, rice, applesauce, or toast, hastens recovery time with AGE. However, if it is easier for patients to tolerate, it can be helpful. Fluid repletion in those who are demonstrating mild to moderate dehydration, oral rehydration solutions such as Pedialyte can be more effective than sports drinks in maintaining electrolyte balance and hydration. If you suspect severe dehydrations, and the clinical signs include tachycardia, hypotension, pallor, and poor skin turgor, IV fluids are usually necessary and warrant an ER referral. There is widespread misconception among the public that antibiotics are the cure-all for any kind of illness, including viral gastroenteritis. We need to reassure patients that acute gastroenteritis is almost always viral and in most cases is self-limiting. Prescribing antibiotics for a viral illness only increases antibiotic resistance and puts people more at risk for contracting conditions such as C. diff. However, empiric antimicrobial therapy is recommended for patients with severe diarrhea suspected from traveling. Trimethoprim sulfamoxazole or Bactrim DS at 1 tablet BID for 3 days is effective. Other antibiotics that are effective for milder forms of illness include ciprofloxacin at 500 milligrams, norfloxacin 400 milligrams, or ofloxacin 300 milligrams. Antibiotic prophylaxis for patients traveling to high-risk areas is about 90% effective. Treatment of one of the aforementioned antibiotics should be given in daily doses, continuing until 2 days after returning home. In the population under 65 years of age, you can consider a 1 to 2 day course of loperamide or Imodium in those patients with moderate to severe diarrhea. If patients have any risk factors for C. diff, so recent antibiotics, hospitalizations, or if they're hospital workers, you should first perform a stool test for C. diff prior to prescribing loperamide. You can also consider a 1 to 2 day course of Zofran or Phenergan for those with significant vomiting. Other commonly prescribed drugs for symptomatic treatment of diarrhea can be seen on the table in page 536 of your textbook. The aim of patient education is prevention of the spread of disease. Proper hand washing is the best way to do this. Any infant or child with infectious diarrhea should not attend daycare until the diarrhea has resolved. Finally, patients traveling to high-risk areas should be instructed to consume only safe foods and beverages. Thanks for your attention, and I hope that you've all learned some good information about acute gastroenteritis.